Good morning, students. In today's class, we will discuss vitamin D3 and its role in calcium homeostasis. The chemical name of vitamin D3 is 125 dihydroxycholecalciferol. Vitamin D is considered as a group of hormone which includes different type of vitamin D like vitamin D2, vitamin D3, the most active form being vitamin D3, and all these compounds together is considered as hormone, that is vitamin D group of hormones. But why this vitamin is considered as a hormone? What is the reason behind this? This is because its mode of action is just like another endocrinal substances. That is, it is synthesized somewhere and being bloodborne, it is carried over to the other target organs where the specific receptors are situated, and thereby it is just like another endocrinal substances. Also, its mechanism of action is like a specific group of hormones, that is steroid group of hormones. Because of that also vitamin D is considered as hormonal substance. By chemical nature, vitamin D is similar to steroid hormones, and so it exerts its action through the similar type of mechanism, that is by utilizing some intracellular receptors, intracytoplasmic as well as intranuclear receptors. For vitamin D, receptors are situated in both cytoplasm as well as nucleus. Vitamin D is lipid soluble, lipophilic, so it can cross cell membrane easily, and it is classified as group 1 type of hormone. So, let us start with discussion about vitamin D3 or 125 dihydroxycholecalciferol. The another name is calcitriol. First of all, let us consider synthesis and activation of vitamin D3. From where vitamin D is synthesized? Vitamin D3 is basically synthesized from its precursor present in the skin named 7-dehydrocholesterol, which is an intermediary of cholesterol synthesis. 7-dehydrocholesterol, from where pre-vitamin D3 is first synthesized by the action of ultraviolet ray acting on the keratinocytes of the skin, and from pre-vitamin D3, which is blood-borne to different organs for further metabolism like liver, kidney, activation process takes place, and vitamin D3 is hydroxylated at different places like liver and kidney to give rise to activated vitamin D3 or cholecalciferol, 125 dihydroxycholecalciferol. The stepwise manner is depicted in this diagram. Let us have a look. First of all, from the precursor 7-dehydrocholesterol, by the action of ultraviolet ray, pre-vitamin D3 is formed, and from it thereafter pre-vitamin D3, which is carried through the blood plasma being bound to a specific protein called vitamin D binding protein, inactive form, that is pre-vitamin D3 is carried over to the liver, where 25 hydroxylase enzyme gives rise to 25 hydroxycholecalciferol. First step hydroxylation takes place. Now, this 25 hydroxycholecalciferol is further carried over to the next organ for metabolism, that is kidney, where hydroxylation at one place takes place by the enzyme 1 alpha hydroxylase, and the end product which is generated at the kidney is 125 dihydroxycholecalciferol, which is the active form of vitamin D3, activated vitamin D3 or 125 dihydroxycholecalciferol or calcitriol. This is the main hormonal substance which basically exerts its action in different target organs like bone, like kidney, like intestine, to regulate the calcium level of blood and maintain calcium homeostasis. Now, while the formation of 125 dihydroxycholecalciferol, there occurs some formation of another inactive or less active form of vitamin D3, that is 24-25 dihydroxycholecalciferol, which is a byproduct while activation takes place at the kidney, and this is a regulatory mechanism to control the active form of vitamin D3 in blood. Whenever the level of vitamin D3 needs to be reduced by some feedback mechanism, 24-25 dihydroxy D3 level gets elevated. In contrast, 125 dihydroxycholecalciferol level gets reduced. That we will be discussing in subsequent slides. Now, let us come to the mechanism of action of D3. I have already mentioned you that vitamin D3 is a hormonal substance being synthesized in the kidney and liver through different hydroxylation process. Activated vitamin D3 is transported in the blood by a specific protein called vitamin D binding protein, and it is taken to the specific target organs, which is kidney, bone and gastrointestinal tract, where vitamin D3 exerts its action through specific receptor which is situated intracellularly. As I have mentioned that vitamin D is a structurally steroid group of hormone, so it is lipophilic and can cross cell membrane easily, and after entering into the cell, like all other group 1 hormone, there occurs binding to the receptor, intracellular receptor, which is present in the cytoplasm as well as in the nucleus for vitamin D, and this hormone receptor complex and then transported to the nucleus, where they gets attached to a specific DNA sequence called hormone responsive element, and this hormone receptor complex, when gets attached to the specific segment of the DNA, the transcription process of mRNA, specific mRNA molecules gets modulated, and this mRNA leads to generation of different group of protein synthesis and expression of specific genes. So, the transcription procedure by the DNA is modulated by the action of hormone receptor complex, and when these messenger RNAs come out, the protein synthesizing machinery comes into play involving endoplasmic reticulum, Golgi apparatus, etc., and specific group of proteins are synthesized. One of such protein which is modulated under the action of vitamin D3 is calbindin or specific calcium binding protein, intracellular calcium binding protein. So, this is the mechanism of action of vitamin D3. Now, let us see how the level of vitamin D3 is regulated in the blood. The vitamin D3 secretion is regulated in the blood by various factors, the most important being blood calcium level itself. In the segment of parathyroid hormone, we have seen that whenever there is fall in ionized calcium, the PTH level gets stimulated, PTH synthesis gets stimulated, and under the action of high PTH, there occurs stimulation of 1-alpha hydroxylase enzyme, and thereby synthesis of activated vitamin D3 is also stimulated. So, it can be said that low calcium and high parathyroid hormone is the stimulus for vitamin D synthesis. And under the influence of vitamin D3, bone mineralization occurs, and there occurs excess calcium absorption from the gut, excess calcium reabsorption from the kidney, and thereby blood calcium level also gets restored. Another stimulus for vitamin D synthesis is decreased phosphate level. Whenever there occurs high phosphate, it suppresses the synthesis of vitamin D3. So, what we get? High PTH, low calcium, low phosphate are the stimulus for vitamin D3 synthesis. And what are the inhibitors? The inhibitors of vitamin D3 synthesis are high blood calcium level, acidosis, any sort of metabolic acidosis, high phosphate level, and excess level of 125 dihydroxycholecalciferol itself. So, whenever the level of vitamin D3 gets increased, there occurs a feedback inhibition of its own synthesis. Rather, as I have mentioned, the formation of less active form 24-25 dihydroxy D3 gets enhanced from pre-vitamin, that is pre-activated form 25 hydroxy D3. In place of producing 125 dihydroxy D3, now 24-25 dihydroxy D3 gets enhanced, and thereby the activity of vitamin D3 is restricted. So, these are the factors. There are certain other factors also, other hormonal substance which stimulates vitamin D3 synthesis, like growth hormone, like estrogen, like prolactin. They are also stimulus for vitamin D3 synthesis, whereas glucocorticoid, thyroxine inhibits formation of vitamin D3. So, these are the factors regulating vitamin D3 synthesis. Now, let us see what are the actions of vitamin D3 on different target organs. The first in series is gastrointestinal tract. This is the primemost target organ for vitamin D3, where it exerts its action to increase the absorption of calcium. Here in this diagram, different levels are marked where vitamin D3 exerts its action at the intestinal epithelial cells. We are seeing that at different levels marked as A, B, C, D. A, that is at the level of the brush border. What does it do? Vitamin D3 increases the permeability at the level of the brush border. Permeability for what? Permeability for calcium, and thereby there occurs increased entry of calcium from the intestinal lumen into the epithelial cell. Now, calcium gets entered into the epithelial cell from the brush border. What happens? This calcium entry is dependent on concentration gradient. In order to maintain a constant concentration gradient across the brush border of the intestinal epithelial cells, the intracellular calcium must be kept at a low level. free calcium level must be kept at a low level so that concentration gradient is maintained. And this is ensured by binding of intracellular free calcium with some calcium binding protein named as calbindin. Calbindin is a specific type of protein whose synthesis is hugely enhanced under the influence of vitamin D3. mRNA for calbindin is transcribed is synthesized in excess amount under the influence of vitamin D3 by the DNA, and calbindin protein synthesis is increased. And this calbindin ensures that intracellular calcium gets bound to it so that the concentration gradient gets maintained. Not only binding to calbindin, intracellular calcium also gets sequestered in different subcellular organelles like mitochondria. This is another action of vitamin D3. Transportation of calcium into different subcellular organelles like mitochondria is also ensured by vitamin D3. Now, whatever calcium enters into the cell, gastrointestinal epithelial cell, also extruded out into the extracellular spaces and thereby into the blood by some calcium dependent ATPase enzyme and also different transporters like TRPV6. TRPV6, transient receptor potential vanilloid type 6, TRPV6. These molecules help to extrude calcium out of the intestinal epithelial cell. Now, these are the levels at the intestine where vitamin D3 exerts its role to enhance absorption of calcium from the gut. Now, let us see what are the effect of calcitriol or vitamin D3 on bone. Bone is the next important target organ where the action of vitamin D3 is almost similar to that of parathyroid hormone. What does it do? It leads to bone resorption by osteoclast, though the stimulation does not occur directly but via osteoblast. As like parathyroid hormone, vitamin D3 also cannot stimulate osteoclast directly as osteoclast does not have any receptor for vitamin D3 but osteoblast has. So, via osteoblastic activity, osteoclast gets activated and bony resorption occur. Also, there may occur osteocytic osteolysis as occurs in case of parathyroid hormone. And another striking action of vitamin D3 is bone mineralization. Calcitriol exerts following action. What does it do? It maintains level of calcium and phosphate of blood constant and their ion product in normal range. How it is maintained? I have mentioned in the first class of bone physiology that for the mineralization of osteoid tissue, precipitation of hydroxyapatite crystal is a must, and this precipitation requires absence of some molecules called pyrophosphate, because pyrophosphate when present it maintains the solubility of calcium phosphate salts, so the precipitation cannot occur. Calcium phosphate salt ionic product, that is calcium into phosphate into the blood, must be above 30 per dl for the precipitation to occur, and this high level is only possible under the influence of vitamin D3 as it increases absorption of both calcium and phosphate from the gut. So, by ensuring the mineralization of the bone, the calcitriol maintains the integrity of bone, and for the removal of pyrophosphate molecules, it enhances synthesis of alkaline phosphatase, which breaks down pyrophosphates so that calcium phosphate crystals can be precipitated. Alkaline phosphatase is an enzyme which is synthesized under the influence of calcitriol or vitamin D3. So, it is another action of vitamin D3 for bone mineralization. Vitamin D3 also ensures osteoblastic proliferation and thereby bone formation is enhanced. Alkaline phosphatase secretion I have already mentioned, and osteoclastin synthesis. So, bone resorption as well as bone formation both are the action by vitamin D3, but the main purpose of all these processes are to maintain blood calcium level. Blood calcium level must not fall below the normal range. This is ensured by parathyroid hormone as well as vitamin D3. Now, what are the actions of calcitriol on kidney and other body tissues? Let us see. The effect of calcitriol on kidney, what does it do? As from the gut, we have seen that vitamin D3 ensures calcium absorption. From the kidney, vitamin D3 ensures reabsorption of calcium and phosphate by increasing number of calcium pump and another type of channels called TRPV5. In the gut, we have seen the channel proteins were TRPV6, but in the kidney it is TRPV5. From where this calcium reabsorption occurs in the kidney? 60% reabsorption of calcium occurs in the proximal tubule and rest occurs in the ascending limb of loop of Henle and distal tubule. And all this calcium reabsorption process are under influence of calcitriol by means of different calcium pump and TRPV5 channels. So, by the action of calcitriol on kidney, blood calcium level as well as phosphate gets increased and the range must not fall under the normal range, that is ensured. Now, let us see what are the other body tissues which also gets influenced by vitamin D3. Vitamin D3 ensures calcium transport in skeletal and cardiac muscles. It enhances stimulation and differentiation of immune cells. T helper cells specifically get stimulated under influence of vitamin D3. So, it has been found that in vitamin D deficiency, different type of rickets, especially in children, there develops susceptibility to infection, immunodeficiency sorts of. So, vitamin D contributes to body immunity. Stimulation of differentiation of skin keratinocytes and formation of cornified layer of epidermis with adequate amounts of protein and enzymes into them. So, vitamin D has been tried with promising result in the treatment of psoriasis, where the differentiation process, maturation process of skin keratinocytes is impaired. In place, there occurs huge proliferation, but maturation and differentiation does not occur. It is ensured by vitamin D3. Regulation of growth and production of growth factors. These are also under the influence of vitamin D3 to some extent, and it has been proved by the fact that in rickets, in children, there occurs stunted growth. So, overall growth and growth factors activity are influenced by calcitriol. So, these are the various actions of vitamin D3 in different organs of the body. Now, if I summarize the action of vitamin D3 in different target organs in calcium homeostasis, how does it look? Whenever there occurs fall in plasma calcium, there occurs increased secretion of PTH, as there is calcium sensors on the parathyroid gland, and by the action of excess parathyroid hormone, the synthesis of vitamin D3, that is calcitriol is also enhanced, as there occurs increased activity of 1-alpha hydroxylase enzyme of the kidney. Now, when calcitriol is synthesized in excess, it leads to excess bone calcium mobilization by bone resorption, excess intestinal calcium absorption along with phosphate, and excess renal calcium reabsorption. So, by the combination of all these three processes, increased mobilization of bone calcium, increased intestinal calcium absorption, and increased renal calcium reabsorption, the plasma calcium level is restored. So, initially though there was decreased calcium level, by the action of vitamin D3, the calcium level is raised. So, this is how the calcium homeostasis is contributed by vitamin D3. Now, some applied aspects of vitamin D3. Vitamin D3 when gets deficient, there occurs different situations which is different from children to adult, and the scenarios are called rickets and osteomalacia. Rickets are basically metabolic bone disorder where there occurs defective calcification of bone matrix due to vitamin D deficiency amongst the children, especially in the growing age, and there occurs stunted growth, bony deformity in different skeletal part of the body, deficiency of immunity, susceptibility to infection, growth retardation, delayed milestone, and there occurs decreased bone density on radiographs. Different biochemical markers are also remarkable in rickets. These are low level of plasma calcium and phosphate. The product of calcium and phosphate is decreased far below 30. Serum alkaline phosphatase level gets higher due to reactionary increased activity of osteoblasts of the body, and plasma 125 dihydroxy cholecalciferol level is very low or absent. So, these are the features of rickets. Now, rickets in children can be of two different types. Specific types are vitamin D deficiency ricket type 1. Vitamin D deficiency rickets, the deficiency may be nutritional and may be deficient synthesis through the skin due to lack of sun exposure. One thing I must mention in this context, that source of vitamin D, though the major source is from the skin keratinocytes 7-dehydrocholesterol, but it can also be supplied from different nutritional substances like egg, meat, liver, fish, etc. Vegetables and milk are the poor source of vitamin D. So, whenever there is deficient nutritional supplement as well as lack of sun exposure in children, rickets is a possibility. So, in case of any sort of deficiency, type of ricket that arises is called vitamin D deficiency ricket. Another type of ricket may be there which is called vitamin D resistant ricket. Vitamin D resistant ricket means here there is no deficiency of vitamin D as such, but due to any specific reason the vitamin D cannot exert its action, or the activation process of vitamin D cannot take place. It can again be of two specific types: type 1 vitamin D resistant ricket and type 2 vitamin D resistant ricket. In type 1 vitamin D resistant ricket, there occurs inactivating mutation of the gene for renal hydroxylase, resulting in non-formation of 125 dihydroxy cholecalciferol from vitamin D3. In such cases, there occurs no response to vitamin D, but a normal response to 125 dihydroxy cholecalciferol is seen. That means activated form, if we can administer, the scenario is improved. But the vitamin D which requires to be activated in the body cannot improve the situation. So this is type 1 vitamin D resistant ricket, where 1 alpha hydroxylase enzyme is defective. Next is type 2 vitamin D resistant ricket, which is due to inactivating mutation of the gene for 125 dihydroxycholecalciferol receptor itself. In such cases, there is deficient response to both vitamin D as well as 125 dihydroxycholecalciferol. So, in no way we can improve the scenario, as the receptor level is defective. So, this is very resistant type of vitamin D, unresponsive to any conventional therapy, that is type 2 vitamin D resistant ricket. So, these are the information about rickets in nutshell. Next is osteomalacia. Osteomalacia can be considered as the adult counterpart of ricket, where there occurs defective mineralization of osteoid tissue in adult after the epiphyseal closure, and due to faulty mineralization process of the bone matrix and faulty bone remodeling process throughout the life, there occurs rarefaction of bone, poor bone density on radiograph, giving rise to different symptoms like formation of bone cyst, pathological fracture, bone pain in different places. So this is osteomalacia. Here the deficiency is mostly occurred due to lack of sun exposure, mainly in Muslim women who uses parda and gets less exposed to sunlight, and the persons who strive on vegetarian diet and milk based diet, who does not take protein adequately like meat, liver, eggs, etc. So in them, nutritional deficiency can also lead to osteomalacia. And the scenario I have already mentioned. So this is due to deficiency of vitamin D. Now something about osteoporosis. Osteoporosis is basically an overall entity clinical scenario where there occurs reduction of bone mass per unit volume. Different reason may be there leading to osteoporosis. Decreased bone density is the main feature, and we know that in bone remodeling process throughout life, to replenish the wear and tear of bone in everyday life, the bone formation and bone resorption continue to occur, which is exactly balanced throughout the life. But in certain situation where bone resorption takes upper hand than the bone formation process, obviously there occurs rarefaction and decreased bone density, giving rise to scenario called osteoporosis. And the osteoporosis may give rise to different symptoms like reduced bone mass on radiograph, formation of bone cyst, pathological fracture, skeletal deformity, which is very prominent in case of spine in old age, producing kyphosis, scoliosis, etc. There may be severe bone pain at different sites. So this is osteoporosis. Now different reasons may be there for osteoporosis. First of all, senile age. With prolonged age, after 40, the bone density starts to reduce gradually in every person, but it is most prominent in case of women. In postmenopausal women, the chance of osteoporosis is much more because there is deficiency of estrogen. After menopause, there is fall of estrogen level, and we know that estrogen normally inhibits secretion of cytokines like interleukin 1, interleukin 6, tumor necrosis factor alpha, and these cytokines foster the development of osteoclast. And we know osteoclasts are the bone which takes part in bone resorption. And the balance of bone remodeling process is shifted towards osteoclast whenever there is absence of estrogen. Estrogen also stimulate production of TGF beta. TGF beta is a factor which increases apoptosis of osteoclast. Osteoclast under certain activity undergoes apoptosis by the action of TGF beta. So when TGF beta is absent, the osteoclast continues to play its role and more bone resorption is resulted, which is a scenario in absence of estrogen. So in postmenopausal ladies where level of estrogen falls, there occurs increased osteoclastic activity by the action of different cytokines like IL-1, IL-6, TNF alpha, and by the absence of TGF beta, apoptosis of osteoclast is prevented. So overall bone resorption by osteoclast gets enhanced. And this estrogen deficiency in postmenopausal ladies increases the chance of osteoporosis. That is why in postmenopausal women osteoporosis is most predominant. How it can be managed? Of course, estrogen therapy, replacement of estrogen after menopause, which was once a definite mode of preventive measure, that is hormone replacement therapy, but it has been found that there occurs increased chance of endometrial as well as breast cancer in postmenopausal women with sustained treatment with estrogen. So it is not tried nowadays. Rather, in place of estrogen itself, some selective estrogen receptor modulator, that is SERM, like raloxifene, has been tried with better result, which does not give rise to different neoplastic changes in endometrium as well as in breast tissue, and also cardiovascular accidents, cardiovascular disorders is reduced in extent than estrogen itself. And raloxifene can prevent osteoclastic bone resorption to a great extent and replace the absence of estrogen, and it has been tried with promising results in case of postmenopausal osteoporosis. Besides this, bisphosphonates are another group of drugs which has been tried in the treatment of osteoporosis in both male and female. Sodium etidronate is a type of drug in this group. What does it do? Bisphosphonates, it inhibits osteoclastic activity and it increases mineral content of bone when administered in a cyclic fashion. It decreases rate of new vertebral fractures. So bisphosphonates are newer modality of management of osteoporosis. Calcitonin analog has also been tried, also fluoride, to stimulate the mineralization of bone. So this is all about in today's class. So what we learned today? We learned about vitamin D3, its chemical nature, that is it is similar to steroid hormones. Its mechanism of action, it exerts its action through some intracellular receptors present in the cytoplasm and nucleus by modulating transcription of mRNA for specific proteins like albindin. It exerts its action in different target organs like bone, kidney and gastrointestinal tract. Everywhere it exerts its action to increase the blood calcium level. Vitamin D gets synthesized from its source in the skin, its precursor, that is 7-dehydrocholesterol. By the action of ultraviolet ray, it is converted into pre-vitamin D3, from where it is carried to the liver where it is hydroxylated at the 25th place. 25 hydroxylase enzyme is present over there. 25 hydroxycholecalciferol is formed, which is further carried to the kidney where 1 alpha hydroxylase enzyme leads to another hydroxylation at one position and 125 dihydroxycholecalciferol is formed, which is the activated form of vitamin D3, which is a hormonal substance. Being liberated, it exerts its action in different target organs like bone, gastrointestinal tract as well as kidney. being bound to a specific protein in the blood, that is vitamin D binding protein. In the gastrointestinal tract, vitamin D increases synthesis of a specific protein called calbindin, which increases the absorption of the calcium from the gut, from the brush border. It also enhances calcium extrusion into the extracellular fluid by calcium ATPase pump, as well as TRPV5, TRPV6 protein molecules. It also leads to sequestration of calcium into the subcellular organelles like mitochondria. In the kidney, vitamin D3 increases calcium reabsorption by increasing the number of calcium pumps and TRPV5 channel proteins. It also increases absorption of phosphate, and by the action of all these target organs, blood calcium level is restored. Vitamin D synthesis is regulated by PTH, which stimulates its secretion. Low calcium level and low calcium level, and also other hormones like growth hormone, prolactin, estrogen stimulates vitamin D synthesis. And its secretion is inhibited by glucocorticoid, high calcium and thyroxine hormone and vitamin D3 itself. Whenever there is high level of 125 dihydroxy D3, its formation is suppressed by a negative feedback mechanism. Rather, formation of 24-25 hydroxy D3, dihydroxy D3 is enhanced. In absence of vitamin D3, in lowered activity of vitamin D3, the resultant metabolic bone disorder is called rickets in children, growing children, and osteomalacia amongst the adult. Everywhere the bone density is decreased, pathological fracture and bony deformity is usually the possible clinical scenario, and supplementation with vitamin D nutritionally is the specific mode of management. Osteoporosis is a clinical entity where there occurs decreased bone density, which is most common in senile age, specifically postmenopausal women, due to deficiency of estrogen, as estrogen normally inhibits osteoclastic activity by suppressing formation of different cytokines like interleukin 1, interleukin 6, tumor necrosis factor alpha, and producing TGF beta for the apoptosis of osteoclast. In absence of estrogen, osteoclastic activity gets enhanced, so bony resorption is grossly increased, so osteoporosis is resulted. Osteoporosis is treated in postmenopausal women by estrogen replacement, which is very much disastrous as it causes endometrial and breast carcinoma. So nowadays it is not used, rather some specific estrogen receptor modulator are used like raloxifene, which does not give rise to those disastrous side effects, rather it suppresses osteoclastic activity. Another modalities are bisphosphonates and calcitonin analog. So this is all for today's class. Please place your queries in WhatsApp. I will try to answer. Thank you all.